This video is for training eye surgeons and for education purpose. Viewer discretion is advised. Hello everyone, this is Dr. Imran Deshmukh from India, and today we'll be discussing phacoemulsification in phacomorphic glaucoma. We got this patient in emergency with phacomorphic glaucoma. We reduced the IOP by using IV mannitol, and we took this patient for emergency surgery. So it is important to notice that these patients have very shallow AC, so it is important to use the side port and main wound very carefully so that you don't injure the anterior capsule. So these are normal steps. What I do is I leave this dye for at least 30 seconds to stain the anterior capsule very well. So after staining, inflate the AC with visco, and I make a CCC rhexis with the cystitome. Make sure you make a star-shaped, you give star-shaped nicks on the anterior capsule. Why star-shaped nicks? So that the intraventricular pressure, the rhexis does not run off, the pressure gets divided into all directions. If you make a single nick on the anterior capsule, there are many chances that it might make an Argentine flag sign, because a single nick has a very big possibility of extending to the periphery. So once this is done, what I do is I take a 27 gauge cannula, go inside it and deflate the bag by aspirating all the milky fluid. If you can see, I'm doing it this step needs to be very careful. You need to be slow and you need to be very gentle. You don't want to extend the rhexis in this case. So I again go inside and try to aspirate as much as fluid I can. So once all the fluid is removed, the bag decompresses itself. So once this is done, I inject visco. And now once visco injected, you can see the AC is gone a bit deeper. So now once I start rhexis in these cases, I always go for a smaller rhexis, because small rhexis can always be enlarged later on. But if you have a big rhexis and if the rhexis runs off in the periphery, it becomes very difficult to operate such cases. So you can see the size of the rhexis is around 3.5 to 4 millimeters in size. Now I'll be going for a spiral rhexis, which is like spirally enlarging the rhexis, and you can see the size is around 4 to 4.5 millimeters. So once the rhexis is done, so now it becomes a normal routine phacoemulsification surgery. So after bringing inside the phaco probe, I make a trench. It's just a routine phaco now. Now trenching, these cases have very soft nucleus, they're not that hard. So I have divided almost one half of the nucleus, rotating the nucleus so that I can go towards the other half. So now trenching and now inserting both the instruments and dividing. Now it's been divided into two halves. So what I do is now go for a stop and chop technique. So go to the center, bury the tip, and by using vertical chop, divide it into two parts. So I'm now removing one quadrant. It gets easily emulsified because these nucleuses are a bit soft. So going for the second quadrant, again bringing it to the iris plane and emulsifying it. And now with the help of my probe, I am rotating the other half of the nucleus, burying it into the center, and with vertical chop dividing it and then emulsifying. Remember, always use ultrasound 4 for the last piece. In ultrasound 4 you have very less phaco power and very less vacuum. This is because so that you don't catch hold of the posterior capsule while emulsifying the last piece of the nucleus. So now once the emulsification part is done, so I now use my coaxial IA for aspirating all the cortex. And now you can see usually in these cases the cortical matter is very less, so you need to be like very careful and slowly aspirating all the cortical matter. And as you can see, there is very less cortex. The difficult part in such cases is the subincisional part. As you can see, the rhexis size is small, so sometimes the aspirating the cortical matter in these cases it becomes a bit difficult, though the cortical matter is very less, and you can see there's hardly any cortical matter. So once the IA part is done, what I do is I implant the IOL in the bag. So use a lot of visco in these cases. I am extending the side ports so that I can later on use my micro instruments like the scissors and the forceps. So now I am implanting the IOL in the bag. The leading haptic goes inside, the trailing haptic is in the sulcus. So use the T-pusher, engage it in the optic haptic junction part, or you can push it inside the bag. See, it's now directly inside the bag. So now once it's inside, you can rotate it. Rotating the IOL helps in freeing all the loosely attached cortex in the bag. So now use visco to inflate the bag. Why I'm doing this is because I want to enlarge the rexes. This rexes is small. So after using my scissors, I make one nick. This nick is not that appropriate. I need to enlarge it again. So I'm again putting a nick in the anterior capsule. You can see that's a nice nick. Now I'm bringing in my micro forceps. I hold at the edge of the anterior capsule, at the edge of the nick, and once you hold that, you're supposed to use centripetal force in the direction force directing to the center of the IOL. See, now we have enlarged the rexes. It's okay, it's quite big. Now one part which I use is manually constructing the pupil. Why? Because most of these cases have a mid dilated size pupil in the post-operative periods, which causes a lot of problems to the patient. They have a lot of photosensitivity. So this is my approach, my technique of constructing the pupil so that you get a good comparatively a smaller size pupil in the post-operative periods. So go in all the directions. Don't use a lot of force. You don't need to pull the iris really hard so that you don't injure the iris and you don't cause iridolisis. So be gentle in this. Catch hold of the border and then slowly direct it towards the center. We want to constrict the pupil, and once this is done, so coming to the other side and holding and bringing to the center. As you can see, you don't want to be very harsh in this step. So once this is done, you can see I'm going in all the directions and pulling the pupil in the center. Now it's time to remove the visco, but what I do is I use the IA probe also for holding the edge of the pupil and bringing it to the center, trying to constrict the pupil as much as I can. Okay, as you can see, I'm not being very violent in this. So once the visco is removed, I go behind the IOL and remove the excess visco. We don't want a capsular distension in the post-operative periods, so excess visco is removed. So yeah, once this is done, you can see the pupil has come down. Now it's time to hydrate the side ports and the main port. So hydrating in the outer 1/3 lips of the main port. So this brings in. I use an air bubble so that to see the anterior chamber is quite stable or not. Now this is the final hydration. So after hydrating, the air bubble becomes a bit small. I hope this video was helpful. Thank you for watching.